Hey there, everybody, and welcome to The Brand Called You. This is a podcast that talks to some of the world's greatest thought leaders, and I think today is no exception. Our guest today is Sam Schrevel. How did I do with my accent? He's sitting in the Netherlands talking to us, and I can't wait to speak to him. And let me just tell you why. As an American sitting here, it's almost impossible for me to listen to any of our elected politicians and not think this person is totally out of touch with the American people. This politician has no idea what it is like to live among the people, to be sick for even a day in this country. And it turns out, according to Sam, this is not specific to America. It turns out that the Netherlands has its own share of governmental representatives and politicians that are also immune to the needs of the disenfranchised, and particularly when it comes to healthcare. And that's why I wanted to talk to Sam. So, a little about him before we speak. Sam is a qualitative researcher at the Hague University of Applied Science Studies, and he's really specializing in healthcare. He's looking at how people experience health and care and how they take part in shaping it. He's told me that good care and good policy really start with the experiences of the people living them. And wow, what a revelation. So welcome, Sam.
Thanks
I,
for
I
having
guess,
me.
listen, the idea of listening to people and actually starting from the ground up seems revelatory. But I think in America, we're always assuming that countries, semi-socialist countries or countries such as the Netherlands, which have a really good, robust, basically national healthcare service, healthcare for all, don't kind of come with these kinds of problems. And I think what you've shown us is that they do.
Yeah, yeah, that's correct. Well, still, like if you compare the Netherlands to other countries, it's still pretty good, but there is a growing part of the population that has problems interacting with the health and social welfare systems. Yeah.
I guess I want to start before we even go on. I mean, most people know what a quantitative research is, where you collect lots of data and you create algorithms and this and that. But could you sort of just very in kind of layman's terms explain what qualitative research is?
Yeah, so qualitative research is the rest, right? So we study stories, uh, language, right? So everything that's expressed in either text or verbal language that we then transcribe and analyze the
But it's really
themes,
it's really the spoken word. It's talking to people. It's interviewing them.
talking to
It's
people, and observing as well. So it's also observational research, how people interact or how they interact with context or situation.
I think that's why I was so drawn to what you do, because I was obviously a professional storyteller, and
Yeah,
I feel like those two worlds, align so beautifully.
yeah.
Listening to what's said and what isn't said, and the word and the unspoken word, and all that. But by the way, what comes to my mind, which is very interesting, was when I met a Scotsman living in the Netherlands many years ago, and he said to me, he said, "We Scottish people, we don't trust the written word." I said, "No." He said, "Because it's only one source." And I
Yeah,
thought there was something interesting in that.
yeah, but that's actually a thing in qualitative research as well, that you have to sort of move between sources to check if
Yeah,
sometimes what you hear from one person in one situation can be much more nuanced or
yeah,
complex than you see or hear at first. So, yeah, we also don't always trust the spoken word, right? So, because that's also a
yeah.
source.
True.
Yeah.
That's true. So let me ask you, you're doing this qualitative research, but your passion has really been for medical systems. And I mean, can you tell me how that started, where that came from, why you were interested, or
Yeah, so the medical field was the only thing I remember was when I was really young that we were on a trip with one of my like a family friend, and he was a GP, and something happened to me, and he had this doctor's suitcase like with all the instruments and medicines in it with him, and I was really intrigued by the instruments. That is when I studied actually medical physics first. So that was my first field. But then it was only a small part. Like the natural
Yeah.
science is a small, is like there's no m meaning. Like, what do things mean? Okay, we found this or that value, but what does it mean? That was not there. And that made me move into the qualitative
Yeah. I mean,
focus on experience. Yeah.
I think your earliest work with, or some of your earlier work was with ADHD
Yeah.
patients, right? So, h- tell me about that. I'm fascinated.
Yeah, so that actually started with myself because I was diagnosed with ADHD, and my first experience with mental health care was that in the beginning it made me more sick. And at some point I had like this list of pills that I was taking, and my problems weren't solved. They grew, and when I sort of figured myself out, like medical or mental health care is still important and they do a lot of important work. So, and there have been very good professionals who helped me a lot, but I needed to do a lot more myself before I could sort of really start to function and thrive again. And then I asked myself, like, am I the only one that has this? Like, you're vulnerable, you're in trouble, and you turn to the people who are supposed to help you, and first they make it worse, and then like I was helped a lot by meditation, and my psychiatrist at the time was like, ha, ADHD and meditate, you can't sit still for a second, right? So that was but it did help me. So
How sensitive
yeah,
of that doctor. Yeah.
very, yeah, yeah. Okay, so that was the start. Like, what am I the only one? And then I started interviewing patients with ADHD, and they had similar experiences. And we also saw that like the way that psychiatry dealt with ADHD was like force structure on people whose problem is chaos. That's not, you don't learn to navigate the chaos. They try to get you into a structure, and that didn't work. Yeah.
Well, how do you think that affected policy, ADHD policy or care systems?
Um, Yeah,
I
so
mean, that
I
lack of
focused on
understanding, that
yeah,
lack of
I focused on adults, right? So for kids it's different,
understanding.
and the Netherlands is with adults. We sort of had one of the first professors, psychiatrists that were specialized in adult ADHD, and their first program was sort of based on the same program as on kids. Uh, but they have actually now included a lot more of other therapies in it. So they are actually quite progressive.
Give me an example of what would be introduced that wasn't there before.
So they were very like 15 years ago. They started experimenting with mindfulness, for example, in ADHD care, and mindfulness was still quite contested. Then, yeah.
I don't
So
know
that
what does that mean exactly?
yeah, mindfulness is sort of the Western uh, interpretation of meditation practice. So it's how to be mindful in things that you do, right? So in being centered, in living in the now, not trying to continuously react to stimuli from your environment. That sort of training.
It's
A lot of
interesting. So
breath.
it's possible to calm the ADHD brain through this external practice.
I did not study that, so I can tell my experience. The thing is, it's not, I can't calm it down, but I can
Mediate it.
uh, bring my attention back more like compassionately. So when I was younger, like you get angry and angrier, like I can't focus, and then
I mean,
um,
what's fascinating to me though is so the Dutch, maybe they are now, but I can hear Americans say there's no profit in doing this. There's, why should we do this training? And where's the profit motive? Because the drug companies aren't making any money out of mindfulness. So I'm
Yeah.
kind of fascinated. I mean, I don't know if you're up against that as well to some extent in
Well, obviously it's there, right? Because the extension of stimulant treatment like dexamphetamine and methylphenidate, uh, that happened here quite early as well. And that was, yeah, obviously also under guidance of pharmaceutical industry, but I think it's stricter regulated. Like doctors don't really like if you go to them and tell them, give me this pill, right? So there's still room for real diagnosis, also in psychiatry. I don't see that the problems in the Dutch mental health system at this moment is really in the influence of pharmaceutical industry. It's more in long austerity measures that have sort of overloaded the system. And now we see more and more signs of venture capital, or not venture capital, like private equity. Private equity, that's one.
so you're
Uh,
succumbing to the same disease that we have, no pun intended.
yeah, yeah.
It's
Um,
not good. What are you working on these days? What kind of research are you involved in?
so my real passion has always been like how is it possible that rich societies produce people that are poor and unhealthy? And that's my because there's an unfairness in that I find
And
hard to take in.
for my American viewers, I mean, is that true in the Netherlands too?
Yeah, yeah, like in every high income Western country, we see that health disparities have always been there, and they are either stagnant or increasing. Yeah.
Oh, I want to hear about this. I mean, A, how are you looking at this? And B, have you come to any conclusions?
So how we are, so the way that I see it is that ill health is a product, right, of economics, policy choices, that sort of thing. But in
Wait,
individual,
go back a minute. It's a product. In other words, it's not just a matter of genetic makeup.
nope, nope. In
Interesting.
lots of
I
ways,
never heard of it referred to as a product, but I actually really like that.
yeah. So that's uh, from social science, the social construction field that looks on how you have the social construction of health, how health is constructed through uh, interactions with other people through contracts, like with a GP, like I can only get this medicine if I go to the GP and explain my
Hmm.
symptoms, and then the GP has to uh, make the diagnosis and give me access to a certain treatment, right? So these are all choices that are being made. Like, what benefits do people get? You also have something like illness benefits, right? So if you get the diagnosis, you get certain benefits that a healthy population doesn't have. You don't have to work. You can get extra subsidies, like that sort of thing. And that is not genetics. That's just social choices.
So
Uh,
you're looking at, sorry, go on. Yeah. So how are you taking this knowledge and applying it?
so what we look at now is in very vulnerable populations. So the group that we work now, we involve them as co-researchers. So they are residents in an area in the Netherlands that is confronted with poverty, with stigma, with marginalization. Uh, and we see problems, especially in single parents. And not only that single parents have the most problems, but their kids also have problems even when they grow up. So it's very hard to grow out of a situation like that. Um, and what we see there is that people's lives in these very marginalized situations is very unpredictable. So they have social benefits for like uh, public transport, for health, um, for their kids, for school materials. But every time that something is broken or they need something, they have to apply for it. They get a call and they have to go. And then they depend on a lot of uh, so, um, social work, which is more like collectively organized, but that is not stable. So community centers open and close all the time, but there is like help with debts, help with finances, like all those kind of things. But when a community center closes, you can't go there to your advisor because he or she is not there as well. So that part, so these people are continuously navigating this context that is unpredictable, and that makes them unable to, you know, get on top of it because they're like thrown around all the time. That
And
is one of the things that we see. Yeah.
have you measured the toll the stress of that has added to their, ill health?
Well, you see it in front of you, right? Because we have this group of parents that we work with uh, extensively over a longer period of time. So we've worked with these parents for now 3 years almost, and like some of them drop out all of a sudden. People come like one person pulls out a bottle of beta blockers for for their heart, and it's not like if my friends would do that, I would be shocked, right? Like you're a beta blocker, huh? And you're like 45. What's and that's like normal. So people don't. It's like part of everyday life. Uh, all these illnesses that are not yet shown up in population data because they're not yet lethal, right? I think that's the problem. Yeah.
I mean, you also, I think you often have written about power struggles within these.
Yeah.
Can you talk to me a bit about that and how that adds to it? And
Yeah. So because and when people get into poverty, there's a lot of uh, even in the socialist uh, like we have a socialist background in the Netherlands, or we tell ourselves that we do. There's some debate about that, but at least there was a quite a strong welfare state through the 70s, 80s, 90s. But nowadays, more and more, we see poverty sort of as the product of people's choices and not of something bad that happened to
so
them.
they're morally corrupt.
Yeah, we're not as far as
That yet.
as America is, but we're getting there. Yeah, so that's um, so there have been a lot of punitive measures on people who made mistakes, right, which push them into more poverty. Right, so if you can't pay your bills, you get fines. If you can't pay the fines increase. So for some small thing like you can't pay your health insurance, €80, you can have a debt of 10,000 eventually. That sort of right. So, but people then live in poverty, and that is always the struggle. That there is this silent expectation that you have to get out of it yourself as well. You got yourself into it, so you have to get out of it yourself as well, and then you are dependent on services and help from others. And there's the power struggle, right? So the power struggle is that if you don't help me, but I'm still dependent on you um, for like a new vacuum, right? Because I need to clean my hands. I cannot be very critical of you, or else you're like deny the vacuum. So there's all these small power struggles that happen between civil servants in the municipality. This is decentralized to the municipality, all this kind of care. Um, and these power balances also influence research projects that we do. We do action research, where we try to uh, help people who find themselves in this position. Like, what can you do to give them a better start, or to give them a nudge in the right direction? And you see these power dynamics play out also in those research projects.
Well, I imagine they must get off on that kind of power to some extent. It must be very appealing to them.
Some are, some are totally oblivious. Uh, uh, they don't know that they have that power. Like, for me, it is really interesting to see that the people who have the least understanding of power are those in power, in positions of power. They really don't understand how it works. Like, they talk about equality and about having like open and transparent communication, and demanding that of others, whereas they are in the top of the symmetry, right? So
Yeah, I've coined a phrase. It's called intellectual altruism.
yeah, that's
What is
they think hard and long about it.
how much does racism? I mean, you've had a tremendous influx of immigrants in the last dozen years or so. How much does that play into some of these behaviors?
I think there's a lot of it still, um, but in a society like the Netherlands, it's more hidden, right?
Mm,
Because we see ourselves as very tolerant, so you can, you know, put out racist slur or that sort of thing. But then we talk about those people, that sort of
have you noticed?
generalizations.
Yeah,
And
I mean, have you noticed a lot of disdain for people of different races within this medical ecosystem?
there is some disdain, especially with single parents and single parents of different ethnic backgrounds. Uh, but then there's also disdain to if you have like uh, white people living in poverty and they have two kids, people also have that disdain,
Yeah,
right? Why do you
yeah,
take two kids if you
yeah,
can?
yeah, yeah,
You
yeah,
know,
yeah.
so that's uh, but there is a lot of insensitivity and also a lack of, I think, interest in in people who don't look the same as you do. And that extends towards people who live in poverty also don't look the same as most people who provide services to people living in poverty.
So,
Uh,
so yeah, you've coined a really interesting phrase called participation shenanigans. Could you just talk a bit about that? I'm sort of curious what that is.
yeah, so if we go back to the power struggle that we see all the time, like not all power conflicts are very obvious, right? So sometimes you have a value conflict or you have a conflict of interest, and those are actually in our kind of research. Those are the kinds of things that you can really negotiate. That you can try to understand why do these interests,
Hmm.
clash, and is there a way out of this? And then we started seeing these weird conflicts um, that had no like apparent reason to emerge. Like, it's really the kind of if he's coming, I'm not coming, or I won't work with that person, but I will work with that person, and then someone else, but I won't work with that person. So this kind of uh, yeah, it's like childish, um, and we decided to sort of look at these situations. We call them shenanigans because we were like, oh my God, these shenanigans again. And then, because for an action researcher, that means 2 nights of calling your co-researchers, like, no, please come to the table. Let's have coffee. Let's talk about it. Like, there's all this work coming out of these shenanigans. So we were like, oh God, please stop it. And then I was like, are we missing something here? Uh, and so we really studied, and we also like linguistically studied these uh, situations, and then we found that they are actually there is a lot of power struggle in it. So uh, residents' experiences or opinions were labeled as gossip, right? And then if something is gossip, you don't have to take it seriously if you're in the in the top of the symmetry. So and then we started seeing that these shenanigans were actually the sort of symptom of these power struggles where uh, very small interactions sort of excluded people, made them silent, um, uh, were actually insulted, like that sort of thing. Yeah.
You know, it sort of makes me wonder whether the fault really lies in the hiring practices to begin with. Like, why are we hiring people without asking them a set of questions which would somehow reveal some of their insecurities or biases to begin with? I don't know. What do you think?
And so for me, we're still in it in the project. So for me, it's also I don't understand it because they are not bad people, right? They're not bad or malicious. They're not trying to make people's lives worse. They actually working really hard for not always very high salaries to make people's lives better, and they do all these things that make it worse. And for me, that's um, very it's intriguing. I would like to study this more, like what happens over there.
Have you brought it up to them yet? Like, are they open to hearing what you've observed yet, or is that too early in your research?
No, so we tried, and most of the time we failed. Yeah, so it is. Uh, uh, but it's with this kind of research, we do participatory action research. It's always in this sort of. It's part of a political system, right? So it is always about benefits, about distribution, about status, about that sort of thing. Because if you want to give people a voice, they need to be given a certain status, right? Else you don't have to listen to. So there's always these political dynamics uh, there, but they're also influenced by larger political uh, incidents. So at this moment in The Hague, the city that I work in, um, there's been a political landslide after the last elections, and that has all these effects on also on street level bureaucrats, right? So the people who interact with people. So you have all these
Just for the people that don't
forces.
know for people that don't know what's happening in the government, it was just describe the landslide you're talking about. It was more to the
Uh,
right, the country's turning more conservative.
uh, yeah, so in many European countries, there's also rise of the populist right or extreme
Right.
right or far right. Um, and in The Hague, the populist right party, I think they, except for one seat, have like majority. Like some,
Yeah.
like it was no, that's not. But it was like we haven't seen uh, a win that big, like
How
in
do,
municipal elections over the last.
how does that affect the ecosystem you're describing
It
inadvertently?
Yeah, so it's always like I say, it's always a co-occurrence. I cannot say that it's like one causes the other, but you see that when he started rising in the polls, you see that the municipality starts closing itself, and um, people are more mindful of what they are saying, to whom they're talking.
Yeah.
So there's a lot of stakes for a lot of people, and the changes with these elections. Like I do research with municipalities for like I think 8 or 10 years now. I've seen some elections, and you always have this. Because the parties change, but bureaucracy doesn't change, right? So there's always this tension between the councils where there's a new division of interests and priorities, and a civil service system that is practically the same as the
Yeah.
the day before, and they have to negotiate that, and then you see that programs are stopped, funding is stopped, new funding is implemented, and then so you get all these changes that sort of trickle down a system like that. But this was landslide. Yeah.
So I can't believe so much 30 minutes has gone by already, but do you where do you want what do you ideally hope that the outcome of this research will lead you, or do you feel like it can be implemented, your findings? Yeah, what are your sort of goals, if you have any?
Yeah. So what if we zoom back into the parents that find themselves in these situations? But their problem is the unpredictability. So
Right,
if you can't plan for next week, like you cannot get out of a certain situation.
right,
So I would really hope that governments try to work on stability in certain services like community centers, um, yeah, social work, um, social welfare programs that don't like start and just drop out, like because that's what makes people also mistrusting towards the government. So the next
yeah.
time someone comes like, hey, here's this benefit, they won't even take it, even though they could benefit from it, right? So if you can make that a little bit more predictable, you can change a lot. Yeah.
Listen, I could listen to you for hours. I'm fascinated by your work, but I really want to thank you for giving us just a small taste of what you're up to in the corner of the Netherlands. And I wish you really
Thank you so much.
continued success with it. We probably have a lot to learn from you. So
Thank you so much. It was great being here.
thank you.
Thank you. Thank you.
Bye.
Thank you for listening to the Brand Called You videocast and podcast, a platform that brings you knowledge, experience, and wisdom of hundreds of successful individuals from around the world. Do visit our website www.tbcy.in to watch and listen to the stories of many more individuals. You can also follow us on YouTube, Facebook, Instagram, and Twitter. Just search for the Brand Called You.